Well, hello again, and welcome to part 4 of our lecture series on vascular anatomy. In this video, we will again be comparing two anatomic data sets. Both of these anatomies fall under the category of incomplete vascular rings. As shown here, we have the left arch with an aberrant right subclavian. I've labeled that LAAR, or left arch aberrant right. And then we also have the anomalous left pulmonary artery, which is commonly referred to as the LPA Sling. These anatomies demonstrate an example of how variably symptomatic vascular rings can be. And I'll explain that more in just a moment. So let's go ahead and start with the left arch aberrant right. So this variant actually arises when the right subclavian takes off from the descending aorta and passes posterior to the esophagus to reach the right arm. It's actually one of the most common anatomic variants that occurs in the general population. It occurs in about 0.5% of the general population, although this may be even higher as it's frequently asymptomatic. And so, although it does have an association with coarctation of the aorta as well as interrupted aortic arch, and it's present in about 38% of patients with Down syndrome who already have congenital heart disease, it's typically an isolated anomaly. That's what I want you guys to remember. It's typically isolated, and patients are typically asymptomatic. And so, just to kind of backtrack just for a moment, you can see here that this aorta passes over the left bronchus, and thus defines it as a left-sided aorta. And then we have our common carotids taking off from a common trunk, which is a common variant that you can see. And then we have our left subclavian here in pink. And then as I rotate further, you see the right subclavian here, which I've marked in white. And although we have had to draw in some of the esophagus, it's not due to compression from this vessel. As I kind of rotate superiorly here and look from above, you can see that the esophagus and the trachea are not completely surrounded in this case. And so this would be an incomplete ring. And so another important point to remember is, as you may remember from our last video, we had a right arch with an aberrant left with a left ligamentum. It was actually the ligamentum that completed the ring. In this case, if you were to have a right ligamentum arteriosum persist, which could pass from the right subclavian to the pulmonary artery, that actually could complete the ring. So again, it's a right ligamentum with a left arch, or a right arch with a left ligamentum. Those two components can complete a vascular ring. And when it has an associated diverticulum, the diverticulum itself can cause esophageal compression, both of which are not present in this case. And so again, most commonly, this is an asymptomatic variant. And so with that, I'll go ahead and move then to the LPA sling. This lesion actually arises when the left pulmonary artery takes off from the right pulmonary artery. And you can see that here. I've actually marked the left pulmonary artery here in white, and it's actually taking off from the right pulmonary artery right here. And so this is in contrast to the previous variant that we described. About 2/3 of infants are symptomatic by 1 month. So it is much more frequently symptomatic and often presents with severe respiratory symptoms, including coughing, wheezing, stridor, episodes of choking, cyanosis, or apnea. And then rarely dysphagia. It's much more common to present with respiratory symptoms. And importantly, this lesion is associated with tracheobronchial anomalies, and that's an important detail to remember. Particularly, it can be associated with tracheal rings, which can lead to tracheomalacia or even tracheal stenosis in up to about 50% of patients. And so the other two associated abnormalities to remember with the LPA sling are GI abnormalities, and those can include imperforate anus, Hirschsprung's, or biliary atresia. And then finally, about 10 to 20% of cases have associated additional cardiac defects, including PDAs, VSDs, or ASDs. And many more different types of lesions that can be associated. And so in this case, because of how symptomatic patients typically are, it does require treatment. And so treatment typically involves surgical division of the anomalous pulmonary artery and reanastomosis with the main pulmonary artery. And as you can see right now, the pulmonary artery itself is passing in between the esophagus and the trachea. And so it's typically resected and then reinserted in the main pulmonary artery. Interestingly, some surgeons actually will transect the trachea itself to avoid transecting and reimplanting the LPA. And so that is another option surgically that can be performed. But as you can see here, there's pretty significant tracheal deflection that is causing the patient's symptoms, and so this will typically require treatment. And so, regardless of that, you can see that from these two examples, while both are incomplete rings, these rings can vary substantially in how symptomatic patients typically are. And so with that, we'll go ahead and conclude our discussion here. We hope that you now feel more comfortable, not only with diagnosing and differentiating vascular rings, but also with understanding the spatial relationships of the structures that cause these rings. I want to go ahead and extend acknowledgement and thanks to my research mentor, Dr. Tannen, along with the faculty that helped develop this curriculum, including Dr. Akimba, Dr. LAAR, Dr. Paroli, and Dr. Seckler from University of Arizona, all of whom contributed to this lecture by contributing content and revising this lecture. And so greatly appreciate your help, and thanks to everyone.